when we're talking about their dental needs, I think that they're more likely to accept the treatment. Humans are very visual, and this is why intraoral cameras have become very popular in dentistry. 15 years ago, when intraoral cameras just pretty much came out, it was a difficult task to incorporate them in our office. I can remember very clearly in the practice that I was working in at the time, it was difficult. It was a hard time to get those the staff to use the camera. They were big and bulky. Nowadays, they're small. They intertwine with practice management software, and we use them every day to help educate our patients about their existing conditions. Radiographs. There's another means of a tool that we use to show patients how they present. Study models. If you mount models and you want to show the patients their existing condition, that's another great tool. But as far as how the teeth fit together on an occlusal level, really, if you don't have a T-scan, we're relying only on paper marks, and patients don't understand what all that ink means, and it becomes really redundant. But people will understand forces. If you explain to a patient that they have heavy contacts, and anytime you have heavy forces on anything, you know, wear and tear on your vehicle, on your car, on your shoes, your things are going to break down, and they will understand that, particularly when they can see a picture of it. Prevention can be broken down into two categories, primary and secondary. Primary prevention are measures that we use to prevent diseases from occurring. So when our patients come to the office, regardless of who they are, who they're seeing, they're either going to present to have some type of treatment, whether it'll be primary or secondary. Primary prevention is there's nothing wrong, and we just offer procedures and education to prevent anything from happening, such as oral hygiene instruction, fluoride treatments if you use fluoride in your practice, sealants, these types of things are primary prevention. Secondary prevention is everything else we do. The patient walks in with a toothache and they leave with a prescription. We've offered them a means of secondary prevention. So understanding prevention and understanding that every single thing we do has a preventive undertone, I think you'll become a better educator. And of course, we need tools to do so. Occlusion in dental hygiene, it's been well documented that heavy forces may lead to both soft and hard tissue breakdown. Not always, but may lead. Patients have an adaptive capacity, and this is why some patients have breakdown sooner than others, or some people can tolerate pain more than others. And we can't have a generalization, but measuring is the only way we're going to know. So in dental hygiene, these are some of the things that we could prevent, from perial pockets, recessions, abfractions, fractured teeth and restoration, sensitive teeth, endo tooth loss, of course, we really want to prevent. These are all means of secondary prevention. And when we can see and identify early signs, and we have tools to show our patients this, we'll become much more effective at getting our patients to commit to certain procedures. It's been well documented that heavy forces lead to problems with the stomagnathic system, which are, in terms, our mouth, our jaws, our muscles, nerves, etc. So we really can be of good service to our patients by doing more thorough examinations. Patients like technology. You all know that. And our dental hygiene process of care is such that we use technology, from a perio probe to intraoral cameras and T-scans, or even some of you may be familiar with Florida probes. All of those tools help us better treat our patients and get our patients to better accept what we're recommending. I'm going to talk about the recall exam or a new patient exam opposed to a periodontal scaling and root planing appointment, because this is where we're going to want to take advantage of the T-scan technology chair side. We currently do hard and soft tissue exams, screen for oral cancer, check the TMJ with our palpations and such, check the muscles, check lymph nodes. We take radiographs. We take photos and models, perhaps, in some of your practices. We educate our patients. And we use all of the information as an opportunity to market additional dental procedures. Okay, so let's face the facts that the dental hygiene chair is a fabulous opportunity to keep the dentist busy doing their dentistry in the next room. And it also is giving your patients a true picture of really what perhaps might be going on. Many dental hygienists scale and root plane and scale and root plane, and you have those unexplained 4 or 5 millimeter pockets that are localized, and the patients have excellent oral hygiene. And if we don't have a way to even rule out the fact that they might have a traumatic occlusion there, that then we're missing part of our patient's evaluation. So the TScan is a great way to add that to what we're currently doing. We use the perio probe. It's a measuring device. We measure. The TScan is also a way to measure. It's data that is objective. It's not subjective. And we don't just probe pockets that we think are going to be more than 2 or 3 millimeters. We probe them all. And this is why the TScan should be used. And if the patients present with balanced occlusion and no problems anywhere, then that's great. We've documented it. It gives you a starting point. And patients are never, ever going to say to you, you're too thorough, you've taken too many records. They want you to provide them with different types of testing, if you will. So we're all familiar with measuring in hygiene, and the TScan is another way to measure how the teeth come together. Early detection is the key. So why wait till it's broken to fix it? These are some examples of things we can look for. Recession. Okay, look at all the recession that we see here. Abfractions, and you're all, that's the word that's very popular in dentistry today is abfractions, and they're not all toothbrush abrasion. Often it's just heavy contacts, as you can see. Recession, abfraction. I'm not saying that these are all caused by traumatic occlusion, but we won't know that unless we can actually measure. And I'm finding that on the patients that we take a TScan on, if we compare it to their radiographs, that often they have heavy contacts in the areas where they have heavily restored teeth or missing teeth or broken down teeth. In this case, here's a case where the patient has endo on the left side, and the TScan will clearly show that